She's a medical consultant, cornea and refractive surgery from Arvind Eye Care Systems, Chennai, and is a very versatile, very graceful surgeon. And I'm sure she's going to tell us a lot, which are still gray areas on the basics and astigmatism management in the manual small incision tunnel. So on to you, Dr. Divya.
Thank you, madam. Thank you for the kind words. I'm once again very sorry about the delay. I hope my slides are visible.
Yeah.
Okay. So I'll be talking about the basics and the astigmatism management in small incision cataract surgery and how do we construct tunnels. So at the end of the surgery, we all wish that we give patients 6/6 vision, and the patient also, looks for 6/6 vision post-op day 1. So with good tunnels, we can actually give very good outcomes even in small incision cataract surgeries. So as we all know, there is the regular astigmatism, irregular astigmatism, and the oblique astigmatism. The regular astigmatism and the principal meridians are perpendicular, and irregular when they are not perpendicular. So these are just the basics. So there is something called the pre-existing astigmatism, which can be recognized by using a good keratometry. And there is something called what the surgeon induces. And there are so many factors that contributes to how the surgeon can induce astigmatism in an otherwise normal eye. So pre-existing astigmatism, again, it would be wise to place the incision at a steeper meridian, which can be visualized with good keratometry findings. And again, the final astigmatic error largely depends on the preoperative astigmatism. So that should also be considered when placing your incision. And we can also modify the wound to make sure that we have a good astigmatism-free tunnel. So cautery, again, this is very, very important because we need a clear field when you have to do a good incision. So it's always good to retract the tenons well before applying cautery, and it is wise to use a wet field bipolar cautery rather than using a ball tip cautery or a unipolar cautery. And make sure you retract the subtenons area well. That's because when there is charring of the subtenons, what happens is there is going to be irregular astigmatism caused by the wound. When you make a wound, it's going to be ragged edges is going to be present, which is again going to interfere with your outcomes. So that is very important. And again, do not apply your cautery after you have done your tunnel. It should always be applied before the tunnel is created. The reason being, once you apply the cautery after the tunnel is created, you're definitely going to cause fish mouthing, and there is going to be, again, a wound gap there, which is going to affect the outcomes of your surgery. And applying too much of cautery in a random fashion over the sclera will again cause sterile shrinkage and can also lead to sterile necrosis. So again, incision characters, we need to decide on the location, the length, and how do we configure the wound. So this is very, very important. As already mentioned, it is good to place the incision at the steeper meridian. And when the incision is too close to the limbus, then again, we're going to induce more astigmatism. And the wound actually has the external and the internal configuration. So the external configuration, again, the size of the wound totally depends on the size of the nucleus that we're dealing with. So a large nucleus, say a grade 4 to 5 or a black cataract, will definitely need a larger incision. So the first diagram here depicts the smile incision, the straight incision, the inverted smile or the frown incision, and the chevron or the V incision. So there are two entities to any incision that we have to consider. One is called the arc length and the other one is the chord length. So the arc length is nothing but it's the line that traverses throughout the incision. So this is the arc length. Whereas the chord length is the point of initiation and the distance between the point of initiation and the point where it ends. So when the chord length is going to be less, then your astigmatism is again going to be less. So that's why the frown incision or the inverted chevron or the V incision gives us less astigmatism, and this is the most preferred incisions. And the other beauty of these incisions is that the ends of the incision is far away from the limbus, thereby creating a better tunnel. So again, internal configuration, it's good to have a 3-planar incision. So the first plane, which is created using the first plane which is created using the crescent blade. It is created in the sclera, and then you dip using a keratome. That's the second plane, and then when you enter into the cornea, that's the third plane. So when you create a 3-planar incision, it's going to give you a good wound position. And again, when the entry into the cornea should be not more than 0.5 millimeters. So that's something that we have to take care of. Too much into the cornea is definitely going to cause a lot of astigmatism. And again, there are high chances of creating a Descemet's detachment as well. So again, the length of the wound is very important. So astigmatism is directly related to the cube of the length, and it is inversely related to the distance from the limbus. So that's why the more posterior your incision, the better it is. However, too posterior will cause difficulty in handling your instruments. So
He's saying you have a minute to go. Yeah.
Oh, yeah. Okay. So again, configuration of both external and internal configuration needs to be considered. There's something called the quartz tunnel, which is an imaginary tunnel. There is nothing but two imaginary lines that moves away from the limbal area outwards. So when your incision is placed within the tunnel, then you have good astigmatism control. So this, when you see the straight, the first picture depicts a tunnel which is too small for the nucleus to be delivered. Whereas here, when you have the smile, you see that it is very difficult for it falls outside the quartz funnel, and here thereby causing more astigmatism. Whereas the straight and the chevron or the frown incision will fall within the funnel, which is going to give you good outcomes. So again, suture, when you apply, we very rarely apply sutures for any SICS case, but when it is done, you have to make sure that you have adequate length, the depth is good. So length, again, when your sutures are equally placed, same size and same distance, then you're not going to induce any astigmatism. Whereas when your length is going to be more than the distance between the two sutures, you're going to induce visceral astigmatism. And when your distance between the two sutures is going to be widely placed, then you're definitely going to induce against the rule astigmatism. So again, tight sutures, two tight sutures will cause increase in visceral astigmatism, and a loose suture will not serve the purpose. So again, it's not going to help you at all. And again, the suture depth should be only about 90%. And as you see, when there will be indentations if you're going to have sutures that are not placed well. So again, only 90. You have to make sure that your sutures are about 90% in depth, and two superficial sutures is definitely going to cut through the tissue, which will again cause increase in against the rule astigmatism, and it's definitely not going to give us a good tunnel. So again, you have to make, if you're applying more than one suture, then it has to be radial sutures. Too tight, you will see radial folds on the cornea, which needs to be avoided. So post cataract surgery, if at all there is any astigmatism, it would be ideal to do a suture removal probably after 3 months of surgery. Again, spectacles, contact lens. We don't do LASIK, but there are a lot of surgeons who do LASIK for patients with astigmatism post cataract surgery. So, so spectacles usually we dispense after 1 month of the surgery, and the suture removal is usually done 3 months post surgery. Thank you very much.
Thank you, Divya. That was a wonderful talk. All the essentials were there in your talk, and really look forward to you involving yourself in the questions which I'm going to ask. We do see some surgeons making a sclerocorneal tunnel directly with the keratome. Maybe they are experts in it, but is there a pros and a cons to it? Divya, can you answer that?
Definitely, any beginner, it's not advisable at all, madam. It's always better to use a crescent to do it, because it's more controlled and the edges are not as sharp as what you would see in a keratome. So it's kind of curved, so you get a good tunnel. I would any day prefer doing a crescent and using a crescent and using the keratome.
But supposing you've had a premature entry and the valve effect is lost and there's going to be iris prolapse, How would you manage these wounds?
So in case, I mean, if you are having a buttonhole in the or premature entry in the beginning, it's always better to suture that site and move away from that site and create a tunnel at another site. That would be ideal.
Dr. Ravindra, I wanted to ask you about astigmatism management. How do you compare superior to a temporal tunnel? And if it is going to be a temporal tunnel, would you need to vary your shape? Like, would you say whether to do a frown or a straight if it's a temporal tunnel? How would you plan choosing these?
Yeah, I think the basic configuration of the cornea before surgery, it's with the rule or against the rule. With the rule, the steep meridian is vertical. You start, I think the best is to mark the axis just like you implant a toric lens for beginners. Mark it exactly 180 or whatever custom you have in your hospital, and then consider this as a astigmatic cornea, and which can be corrected by your surgery. If it is with the rule, imagine the steep axis at 80 degrees, you start the surgery at 80 degrees. If it is at 110, you start it at 110, 105, depending upon that. If it's against the rule, most of the corneas are against the rule. As you know, 80-90% are against the rule. So straight away you identify the steep meridian on the horizontal axis and start on the temporal side. Either when you do on the superior side, the bridal suture is necessary for many patients, unless especially if you give a block, you can't ask the patient to look down, so you need to have a bridal suture. That's one big advantage of selecting the temporal. And then the prevalence of against the rule astigmatism in that age group is very, very helpful. Consider about the incision, whether straight, frown. See, that's important only if you're going to do very close to the limbus. But if you're anyway starting 1.5 millimeter behind the limbus, and then if your incision is not too big, imagine you're not going to do 8, 9, 10 millimeter incision. In my hands, my experience, the frown or smile or straight has not given much difference. So it's convenient for me to do a straight incision. I'll switch over from frown to straight long time ago. And we do preoperative and postoperative care reading. That's what I would recommend everybody, to do a preoperative care reading and post-op care reading at the end of 1 month, and then do the vector analysis. Just like one cylinder before, one cylinder after, doesn't make a sense. The axis is different. So you'll have to go back to the formulas, vector analysis, then you'll be able to analyze your results much better. It's nice to have a sheet wherein you have given input data, like what is the size of the incision, how far away is from the limbus, what's the length of the incision, is it frown, and have you extended it laterally, did you stretch the wound during surgery, how much you cauterized, and all that you put it as analytic data inputs, and they find out your results. I think each surgeon has a signature, and his astigmatism varies depending upon the type of surgery he's going to do.
Yes, Dr. Sahu, yes.
Yeah, because see, bridal suture, as Devasi said, people should not be encouraged to use it. We are totally no. So maybe it's not good. And we can do all kind of surgery without bridal suture. So that should not be encouraged for the younger students. Now, next thing is that temporarily you were asked temporal incision. There is no need for a frown incision there because the fibers are arranged in a different way. So straight incision is the thing, because that will not reduce much of astigmatism, but straight incision is the thing that has to be done. Right. These 2 points I wanted to say. Bridal suture we are discouraging totally.
Okay, then when would you tell a beginner surgeon to put a suture to his sclerocorneal tunnel, Dr. Deepak?
If he's not sure about the valvular effect, sometimes the surgeon creates, and if he's not certain that the valve is functioning, then it is better to suture the wound with one single 10 nylon radial suture. Or in this case where he's used a very large superior incision, it's going to induce significant amount of astigmatism. To counter the astigmatism, he can always use a single stitch, which is going to counteract by inducing withdrawal astigmatism. So these are the two scenarios where I would recommend a beginner surgeon to use a suture.
And also, if he has placed it opposite to the steep axis, then also he could.
Yeah, usually most of the patients are having against the rule.
Yeah.
And if you place a withdrawal astigmatism, it's going to worsen.
Worsen
So
it.
in those situations, I think a single radial suture is going to counteract a little bit better.
Yeah. So when you make this tunnel, you would start by creating a groove probably. So if you do that, would you advise a 15 number blade for that, or would you advise having a guarded knife for that?
I think nowadays we have the luxury of having the depth defined guarded blades. But we all learned with just the regular bar Parker blade. But if you can afford one, definitely you can go with the one with many half thickness scleral pre-grooved blade are there. Those would be ideal if you can afford one. But otherwise, you can just learn. With a few cases, you get the hang of it.
Yes. Thank you very much. Anything else to ask, Dr. Anita? Yes. Yes, Dr. Devash.
About the incision.
Yes.
I think for beginners, what we have usually observed that the eye is curved like a globe, right? And so when you start the incision, you are a little shy, whether you use a Bart Parker or you use the splitter. So usually the initial part of the incision is a little shallow, and the middle part becomes deeper. And again, in the periphery, it becomes shallow. So essentially, if you see that this ultimately guides the scleral tunnel. So you have a buttonhole usually in the periphery, and as you were saying, the premature entries would occur in the center. So I think consciously a beginner has to be, he has to be taught or brought into their head that this is a common thing that you are on, and you can be safe. And let us understand one more thing, that SICS surgery has another big thing, because it can correct significant astigmatism. You can take up an eye with, say, 1.5 cylinder, 2 cylinder. With an OCCI, I think it can give you a correction up to 2 cylinder. So essentially, if a patient cannot afford toric lenses, you might as well choose the patient to give him a little more tissue dissection, even in a softer cataract, and give him the benefit of post-operative, no astigmatism over phacoemulsification. So SICS is a good surgery even to correct astigmatism.
Yeah, but I think for a surgeon who's doing it very in a titrated manner, maybe you could compare with torics, but otherwise I would keep
very
in mind
grossly
that the wound
speaking,
drift which can occur in large incision.
Yes, I mean, if you are doing it over and over again, you can develop your own nomograms like Boromani has done. Yes. So he can correct predictably astigmatism, then he can know what would be the residual astigmatism in his surgery. So
yes. Dr. Saurabh, what about the wound drift which can occur in these large incisions? We know that, but anything newer which has happened which supports SICS more?
Yeah, I think that is the major concern, because most of us, of course, in phaco also, we see very short-term results. Yes. And when we see this patient after 2-3 years coming back, and we have corneal remodeling, and we never know what will be the final effect. Yes. Of course, I think there are many surgeons who have done probably long-term studies. I think they have operated for years together, so they will be in a better position to tell. Yeah. And it's very subjective, because surgeon to surgeon, I think skill levels are quite different. But what I have seen, whenever superior incision is taken, there is definitely a drift over a period of time. And sometimes it is beneficial also, because this astigmatism may add to some near vision, uncorrected near vision, as is proposed. Yes. But I think that, for me at least, remains an unpredictable area of SICS.
Yes. Thank you very much. That was a wonderful discussion.
Can I just add one point here?
Yes, sure. No, very important astigmatism. Yes.
About the tunnels, I think Dr. Divya beautifully presented her submission. But one thing is, what I would recommend is, if there is a premature entry or premature exit, then you can actually, instead of going to another place, you can start in the same place again, go up or below the initial tunnel, and then you can complete it in the same way. So that's what I just wanted to submit.